One. People meeting 5.
All right,
Yeah.
good to go.
Oh, you.
All right, I think we're gonna get going. Sorry, I think we're gonna get going. Unless we had like any heckling from the audience. Be warned, Cindy may heckle Christian. All right, so welcome to Grand Rounds. We have our newest rheumatologist, I think. Yeah. Christiaan Scott, not new, but newest to us, presenting today. Ottawa is built on the unceded Anishinaabe territory, and the peoples of the Anishinaabe nation have lived on this territory for millennia, and we honor them in this land. Christiaan Scott is a professor of pediatric rheumatology at U Ottawa, and he is the former head of peds rheumatology at the University of Cape Town and the Red Cross War Memorial Children's Hospital. He's also, I think, the most regular in-person attendee of pediatric grand rounds and always asks at least one really insightful question. I think you have to add that to your bio, Christiaan. His research and education work focuses on the care of patients with rare and rheumatic diseases in less resourced communities. He has a special interest in education and access to care in MSK conditions, especially in FOP, which he will be talking to us today, including what that stands for. He's the chairperson of the Global Task Force for Peds Musculoskeletal Health and the medical director of Tin Soldiers Global, a rare disease identification program. Finally, a member and former chair of the International Clinical Council for FOP. He serves on the editorial board for Pediatric Rheumatology Online Journal and Best Practices and Research Clinical Rheumatology. So I actually thought I'd read the entire thing out because Christiaan's actually doing a lot of international work and has been a great colleague to join us in the last year or so. So Christiaan, with that, come tell us about FOP.
Thanks very much, Pranesh, and thanks everyone. It's really great to be talking to you all. It's a little bit nerve-wracking talking to all of you because this is my new home and it feels kind of personal. So it's great that I've been given this opportunity. But I'd like to start off by thanking, if I can advance my slides. Have I done?
Just one slide.
I just have one slide. Yeah, it's going to be a 45-minute monologue.
There you go. And you can go back with Peter.
So I'd like to start off by thanking the rheumatology team who've welcomed me here, who gave me the opportunity to come here and who've welcomed me and made me feel at home. You can see we're a close bunch, and I'm really grateful to them. I'm as grateful to the executive and to Pranesh and everyone who's made me feel welcome here in Ottawa, and all those of you people who have stopped at my office to introduce yourselves. I'm very grateful. So these are my disclosures, and the reason I mention some of them is that I'm obviously the medical director of Tin Soldiers, but the reason I mention the ICC on FOP, the International Clinical Council, is just to say that the things I express here are my opinions, are not necessarily representative of the ICC. So I like to look at the world in terms of healthcare as an apolitical thing. The whole people are living everywhere on this strange pale blue dot, and the borders that we put around ourselves divide us, and they cause great friction, especially kind of more to the south borders. And healthcare should span these borders, and everyone, no matter where they live, should have equal access to healthcare. So this is a fundamental philosophy for me in healthcare. So the whole talk from here on is in Portuguese, as you can see. But I flashed this up just to give you a clue. This is a Portuguese law, or at least a Brazilian law that's recently been passed, and I'll come back to it. But you'll see one word here: if fibrodysplasia ossificante progressiva. So I'll tell you what the law means eventually. But it's curious that Brazil has a law relating to FOP. Now you're mostly other specialists, not pediatric rheumatologists. You might be general pediatricians, you might be medical students or fellows or residents, but the philosophy of this talk as well is based on this notion that it's nice to know a little bit of something about everything. Well, you don't have to know everything about everything. So it can be overwhelming and annoying when people come and give you a talk on some rare thing and they expect you to remember all of that. I completely get that, but I just want you to remember a few small things about this condition. And this philosophy, Thomas Huxley was the grandfather of Aldous Huxley. He was known as Darwin's bulldog for supporting the evolutionary theories and so on. And he was the first editor of Nature, and this was his philosophy. And you can see this guy, Nature publishes on all kinds of science, and all of it is interesting, but you don't have to remember all of it. So here's the first case presentation. This child comes into your office with a lump on her back, or this neonate with 3 lumps on the back of their head. As a general pediatrician, you'd be forgiven for thinking, or an emergency doctor or someone in the community, you might think, well, what do you do? Do you MRI this? Do you think it might be a malignancy? Do you refer to oncology? Do you refer to orthopedics, general surgery? Do you send for a biopsy? What are the kinds of things you would consider doing in this child? And the reason that I give this talk is really based on the principle of first do no harm. Because if you're one of the people who thought, well, those lumps clearly need to be biopsied, which you'd be absolutely forgiven for thinking, you might have inadvertently caused quite a large amount of harm to one of those young people. Because what these 2 kids have is fibrodysplasia ossificans progressiva. This is a rare condition, 1 in a million people, where all skeletal muscle and tendons and ligaments slowly over time ossify and become bone. So there's this process of heterotopic ossification. And the diagnosis is very straightforward. Before the person looks like the slide I just showed you, this is obviously very easy to diagnose as well, but this diagnosis could have been made on those 2 early children very early on, very easily without doing any special investigations like biopsies or anything like that. So the diagnosis is easy, and misdiagnosis can be extremely harmful. That's the origin of all of this work. And this is how you make the diagnosis. The diagnosis is made easily just by looking at the big toes of people who present with lumps, or just by looking at everybody's big toes. The big toes are short and they're in valgus, and they might be missing a joint. You might have seen toes like this before, but hopefully from now on you'll look at them with a slightly different lens. Because when you have great big toes that are deformed like this and you have lumps on the back, as those 2 children presented with, like there's not really a very big differential diagnosis. It kind of has to be FOP. This picture on the right is an old picture of what used to be called Stone Man syndrome. This is a book that I have in my house. I got it from my grandfather. It was published in the 1800s. And it's a very long story of the ossified men, as you can see up there, with ankylosis of the articulations. And they go on to describe the clinical picture of FOP beautifully in this book from the 1800s. And some of the sketches are indeed from the 1600s and 1700s. But you can diagnose FOP in this man just by looking at his big toes on this sketch.
Christiaan, are there formed fruits? These are very dramatic presentations. In addition to those, are there milder kinase mutations leading to?
No, actually.
It's binary?
It's quite binary, yeah. The toes are not always that dramatic, but if radiologically at least, they're always shortened, the first toes. There are many other radiological features, like thumbs could be shortened, certain carpal bones are shortened, there could be enchondromas and so on, but the diagnosis can be made even antenatally just based on looking at the toes.
Are there kinase genotypes that lead to less prominent swelling? Or
No. It's very consistently expressed. In this condition, there's one example of a teenager who didn't progress, but the rest progress almost textbook-like along this pathway. So the reason we're so concerned about biopsies and not biopsying it is if you injure the muscle in someone with FOP, what you end up with is new bone formation in the area where you've biopsied. And so if you injure muscle anywhere in the body, the muscle needs to be replaced, and that acts as a signal for the mutation that's present in FOP to make new bone, and that sort of triggers the whole bone cascade and starts it off. So, for instance, a mandibular block for a dental procedure might result in the masseter muscle becoming ossified very early on, and that can be dramatic. An intramuscular injection, such as for an immunization in the thigh, if someone's got FOP at 18 months, can be dramatic because it can lead to ossification around the hip, and that child will never walk again once that heterotopic ossification is formed. So you can literally inadvertently take a child from being able to eat a full normal diet to never being able to open their mouth again for the rest of their lives. And there's no therapy that'll make that mouth open up again. It is that dramatic. Or you could take a child who was running around at the age of 3 and have them in a wheelchair by the age of 3 years and 1 month if you inject. I am trying to terrify you. This is why I got into FOP, because it terrifies and horrifies me every day. So what happens is that because of this mutation in a gene called ACVR1, which is a receptor, a BMP receptor, a bone morphogenic protein receptor, you get excess BMP stimulation, and I'll talk to you about that, but the body tries to build a new skeleton. So it takes the pluripotent mesenchymal stem cells and drives them away from a muscle lineage and into a bone lineage, and you end up building a brand new skeleton for yourself where your muscles are rather than where your skeletal bones are supposed to be. And so you'll see that children who develop FOP progress in an embryonal fashion. You saw the baby with lumps on the back of the head. Well, that's where your skeleton starts to be made. You saw the older children with lumps on their backs. That's how it goes down and then out. So your body is literally trying to build you a new skeleton by replacing injured or dying muscle tissue. So the mechanism is a little bit complicated, but I'll make it very simple for you. This is the ACVR1 receptor. Normally, BMP binds to that receptor and ends up causing genetic expression of enchondral ossification genes in the nucleus. So basically, it drives bone formation. Activin A is in the TGF beta family. It's something that controls inflammation or gets released in inflammation. It's got a number of other functions, but one of them is to regulate inflammation in the once it gets into the nucleus. When you have this mutation in ACVR1, which almost everybody has this R206H mutation, what happens is the BMPs and the activins both behave like BMPs, and so you have this constant signal for bone formation because the thing that's supposed to regulate inflammation is actually causing bone formation. And so that's what happens. You get endochondral genes from even the activin A. So trauma and infection can sort of stimulate this, and there's some evidence that the immune system in FOP is primed for an innate immune response. There's a baseline inflammatory milieu, and IL-1 and IL-6 and other inflammatory cytokines are elevated at baseline. But then when there's damage, pathogen or infection, such as damage-associated molecular patterns, DAMPs, or pathogen-associated molecular patterns, PAMPs, then you get this stimulation of a lot of these inflammatory markers, and that contributes to the activation of the heterotopic ossification pathway. And then what happens is once you've started on that pathway, you get the gene expression for BMP happening, and then that goes to fibroproliferation and angiogenesis. Then you get early chondrocytes forming, and eventually you get mature, normal bone formed in your muscle. And that's where you end up with heterotopic bone. And this slide also tells you where the various steps are where you can intervene in this pathway. So these are the classical features. A child can be born with toes like that and can have FOP diagnosed. Usually it doesn't happen. And a child can have painless swelling at the back of the head. Not an uncommon finding in neonates, especially those who've had traumatic deliveries and forceps and so on. But if you see this with those toes, you need to be thinking of FOP. Then in the first decades, people start noticing perhaps a little bit of stiffness of the neck, and the lumps start forming. And then as children get older, eventually by the second decade, mostly people are immobile, not able to walk, and by the third decade, completely ossified. So imagine this can cause scoliosis, obviously, restrictive lung disease, pneumonia, respiratory complications. But one of the biggest problems, and the thing that bothers me the most as someone who's a bit of a foodie, is this jaw ankylosis, which stops people from being able to eat a normal diet. So they literally have to liquidize all of their food, or have to push food in through the side of their mouth into the back with their fingers to try and get food in. What's worse is eventually people can't even move their hands and can't even get to their mouths. So they've got no real way of feeding. So someone actually has to feed and push food past their teeth and into the back of their mouth. It is really one of the most devastating things to see. They can get terrible dental problems because they can't open their mouths, they can't brush their teeth. They might develop abscesses, and it's very difficult to do dentistry on these people. They are a huge anesthetic risk because the neck can't flex, the mouth can't open, so you can't intubate these people readily. And it's a massive undertaking to do surgery, and you need specialist anesthetists to be able to do that. And the FOP world is fortunate in having many specialist anesthetists who specialize only in this, as well as FOP dentists. They obviously can develop falls. When I first diagnosed a patient in South Africa, I went looking. I was horrified by this condition, and I went looking for all the people around that had been identified. I found Professor Byton of the Byton criteria, the hypermobility criteria. He was the geneticist at our hospital. I said to him, "Have you seen any of these patients before?" He said, "Yes, in 1976, he diagnosed 6 people, and he wrote a paper on it." So I said, "Well, I'm going to go find these people and see if they're still okay." One of them had, I found 3 of them, and one was on his way to clinic one day, and he fell and broke his neck and died on the way to clinic. So this is how dramatic the falls are, because people can't lift their arms. If they don't have a wheelchair or some assistive device, if they fall, it's very, very dangerous because they fall straight like a pillar onto their heads, and they develop fractures. This is one of the young children that I diagnosed in Cape Town. She actually passed away from respiratory complications at a very young age. She was frozen double, so that she needed to be lifted up around to be able to look at the world. I've seen people with FOP whose heads are frozen. They can only look through their legs at the world. They've doubled up, and there's no way of coming back up straight. This, no, don't worry, it gets better. This is a child with FOP, and also that's my old clinic at Red Cross. You can see he needs to wear a helmet because he falls frequently. He doesn't like his helmet. He likes the dinosaurs more. And here is a sort of a picture that tells you the story of the life cycle of FOP. This is a child. You can see she's got one elbow flexed, but she's still able to run around. She's got a fixed neck. This is a 20-something-year-old. She's in a wheelchair because of one of her legs is completely frozen, but she can still bend her arm. And this is a 60-year-old male who can literally only move his fingers and his eyeballs and his tongue. So naturally, these people have a shortened life expectancy, and cardiorespiratory failure is the main reason for this. But of course, there are other reasons why people die: falls, drowning, etc. Quite depressingly, starvation as well because of the jaw ankylosis. How do you care for people with FOP? Well, the first thing, and the reason I got into this, is to first do no harm. Identify people early and then stop making things worse. That's generally a very good starting point in this condition. And when I first got involved with this, there was no therapy. There was not even really a hope for a therapy. The gene was only discovered in 2006. But there are many ways you can prevent complications: by doing good dentistry, by adhering to good oral health, managing the anesthesia, which is very difficult, doing audiology testing because the ossicles ossify, or the muscles around the ossicles ossify and people become deaf. There's lung health issues that you can look after, trying to keep people breathing, encouraging them to sing, inspirational spirometers, that sort of thing. there's a lot of physical aids. We've got a whole physical aid toolkit where you can get a fork on a stick this long so that you can pick up your food on the table over there and bring it to your mouth just like this. Or you can comb your hair, or you can do self-care. We've got shirts with zips on the back so that you can just, there's collared shirt, buttons on the front, but a zip at the back so someone can just slip you into your shirt and zip you up without you having to try and fiddle with buttons. And there's a whole suitcase full of things that have been designed by people with FOP. But the main thing is you can avoid biopsies, you can avoid injections, you can avoid surgeries, and you can offer wheelchairs and mobility support. And nowadays we're in the fortunate position where there's medical treatment coming. These are all the drugs currently in clinical trials for FOP. Some of them, like this retinoic acid receptor, palovarotene, has actually already been approved. Canada was the first country in the world in which this drug was approved. Unfortunately, the drug costs around $1 million a year. Rapamycin was in clinical trials. There are activin A antibodies. There are ALK2 inhibitors, a number of them in study and so on. So there's a lot of development in this area. So there's an added impetus to find people with FOP and to diagnose them. So this brings me to the main thrust of the talk, really, which is where are these people with FOP? There are about 900 cases known in the world, and we know that it's 1 in a million mutation that happens, and it doesn't change between different populations. And we know there are 8.1 billion people and rising in the world, so there should be 8,000 people with FOP. This is a study that we did looking at where case reports of people with FOP are reported. So these are all case reports of people with FOP. You can see lots or publications about FOP. You can see Europe, South America, North America, especially the USA, and then and lots of case reports in Asia. But there's a slight discrepancy here in that there are many case reports of people with FOP in Asia, for instance, but if you actually look at the number of patients known in the Asia Pacific, it's 132, and yet 201 case reports have been written on these people. So that tells you people get diagnosed and disconnect from care, which is what happened to me in South Africa when I went to go find those kids who were diagnosed in 1976. So in about 2010, I took all our South African FOP patients on a big trip to Brazil because we were lamenting the fact that nobody talks about the Southern Hemisphere FOP, where are all these missing patients? So I met up with my Brazilian colleague who had diagnosed most of the kids in Brazil or people in Brazil, and we had our first FOP meeting. And at that meeting, there was a film producer who had been asked by one of the philanthropist mothers of one of the FOP people living with FOP to come and film this. And this resulted in a full-length documentary called Tin Soldiers, which I can hook you up with a viewing if you'd like. But this told the story of people living with FOP and the difficulty of diagnosing people the world over. But this documentary, then eventually became a patient-finding organization called Tin Soldiers Global. So we've had lots of meetings and lots of educational interventions to try and educate people about FOP. And then we've traveled across rural parts of South Africa, India. We've got programs running in Russia and all over the place trying to find people with FOP. So here's a little movie, just a public service announcement. This played on taxis in India and in South Africa to try and sensitize the general public about FOP. And this is the work of Odette Schwegler, who's the film producer that came and made that movie. So we're using the storytelling to kind of get people to care about FOP. So I hope you can hear. The sound is as loud as it'll go. I'll turn it around so you can hear better.
My name is Landry. I am 7 years old. I am funny.
I love to dance and sing.
I'm stubborn. I'm determined.
I would love to become a teacher.
I am brave. I am 1 in a million.
And I'm proud to be 1 in 1 million.
Someone like me is born every 44 hours.
So that's just a taster. There'll be some more videos if time allows, which I think it will. So we do a lot of communication. We try and spread the word, lots of publications around the movie and so on. And then, and we've had some success, and I'll tell you about this, but this story illustrates it for me. I got this video sent to me through YouTube. That's a language local to Uganda. And someone said to me, we think this video shows a patient in Uganda with FOP. And I looked at the video, and you can see this child's horribly has got horrible deformities. But if you look at the video, you can actually make out the toes, and you can diagnose this kid with FOP. I found a fellow in our hospital who spoke this language, and we contacted the family, found out that they had been trying to raise money to take this child to India for surgery. And by the time we had gotten a hold of them, the child had already died. And people had been trying to correct the spine and to crack bones and to break things right again, which has obviously resulted in the death of this child. Fast forward that to late last year, when one of the people who had been to one of these FOP talks was looking through someone else's cell phone, and they were looking for pictures of their family to show them. And they said, well, what's that? Because this picture popped up on the mobile phone. And the guy from Ghana said, oh, this is some child with the rare disease. We don't know what's going on. We have no idea what it is. And she said, but I know that I've seen this. Look at the toes. This is FOP. This is someone called Kelly Duplessis, a rare disease advocate in South Africa. And she was talking to this other rare disease advocate who was trying to find a solution for this child. She made we can make the diagnosis here. There's the toe. You can see it yourselves. The most obvious diagnosis of FOP ever, with one of the most severe phenotypes at this age that I've seen. Anyway, we were able to connect this child through the global task force and everything to a care provider in Ghana who trained in South Africa, and that child is on a care pathway where at least they won't get any more biopsies or having any more corrective surgeries and so on done. So why does this matter? I mean, one of the main things for me is that all children in Canada with FOP haven't been diagnosed. I'll show you some stats. The first ever treatment for FOP has been registered in Canada, and there are several clinical trials enrolling, and there'll be more treatments. And if you think this can't make a difference, wondering about a rare disease like this, I'll give you some examples. Tin Soldiers has, in 2 years, just by doing this kind of talk, found 77 new patients with FOP all over the world. That's from Australia to Russia to many parts of Africa, 33 new patients in India. We had a patient in South Africa, one of twins born, and the doctor had been to one of these talks and said one of the twins had abnormal toes. This is at birth. The patient was diagnosed with FOP, sent to us. We did the genetics, and one of the twins has FOP and the other one doesn't. But that child is now 3 and has had all the right preventative care for someone with FOP and is waiting to get onto a clinical trial as soon as they come down to her age group. And then there are many other, I won't go through the locked jaw example. But as we were looking for people with FOP all over the world, we realized that musculoskeletal examination was very underdone in much of the world's curricula. And we would go into rural villages and talk to people, and we'd find that people just didn't have any idea of examining the musculoskeletal system in general. So part of my work with the Global Task Force is I'm the director of this thing called pmmonline.org, which was founded at Newcastle University by Helen Foster. It's a free website where you can learn about musculoskeletal conditions and examinations. You just have to register, and then there's all kinds of resources for you to use, including this thing called PGALS, Pediatric Gait, Arms, Legs, and Spine, which is a downloadable app which Helen Foster developed, and which will soon include the toes of FOP, by the way. And you can run through this examination technique, and it's a great way for fellows and students, medical students, to do a quick musculoskeletal screening exam to look for things. So we have started using this app to try and develop the find more people with FOP on the one hand, but also just diagnose other people with rare conditions. And so we've started a pilot project teaching this PGALS app to people to a group of nurses in South Africa. They're called the Unjani nurses. They work out of train containers or shipping containers. They've got clinics all over South Africa in the poorest of the poorest areas, and they are literally the first line of defense for many people with healthcare problems. So here's another video which tells the story of this project that we're doing. So all of these joints are normal. It's well known that the burden of infectious diseases and other diseases drown out the diagnosis of non-communicable diseases, such as juvenile idiopathic arthritis, never mind something as unusual as FOP.
There is a worldwide need for pediatric musculoskeletal disorders screening. These kids can't be neglected any longer.
So the whole body becomes trapped in all of this bone. And we look at her back to see that the spine is straight and that the hips are straight at the back as well. Symmetrical. So that's another big thing. 26 patients in Africa. Just walk normally. You can then decide, okay, that's fine, that's fine. It was looking outwards. And when we looked at his spine, his neck was completely stuck.
The overall goal of the project is to try and train as many primary healthcare nurses as possible. They're professional nurses that work in primary healthcare in the communities where they live.
I love nursing. I love seeing the community say, because of you, because of your clinic, I'm better.
We're going to look at the child from the front, from the back, from the side. We're teaching them how to do a simple but very effective musculoskeletal examination. You don't want him to bend over, and then you do the other side. And that's called the Pediatric Gait, Arms, Legs and Spine Examination, or the PGALS.
When I was here, my phones, I've been a nurse for 10 years. And I have never heard about MSK.
So the ankles are supposed to be in line, that with your one hand. So whenever a child between 5 and 16 years old comes to the clinic for whatever reason, they will offer them the opportunity to have this examination.
Let us screen them so that anything that is suspicious, we can pick it up early and then we can be able to refer them.
So we're providing them all that support and help them then to facilitate the referral. Yes.
Screening is important so that we can be able to refer the child on time. Even at home, we can just assess the child who's playing with your kids, find that this child is having a problem.
And by having those skills, the nurses will be our eyes and ears on the ground and also know the community, so it's easier for them to identify these patients.
Then I'm very grateful to be part of the training, because you know what is happening here in Botshabelo. In most of the time, we are the last hope of this community.
And now it took me back to say, you know, I've seen so many kids with the same problem, but I did not know what it was. If only I had known this earlier, most kids would have been saved.
Operating Palmwell. Ini kita sama. Coba lu kumana na. Demi na hakimu wala. Nagawa po.
Sure, I thought dinner wrong. But this one very worrying.
Hey,
So haholo o lla ka ntho ka mangwele ha tshekuwa ke bo sister ba fumana go mangwele ha e halekane a ruruile ke mo bo sister ba le bang bolela go ona le arthritis.
And when she brought back a patient that she thought might have juvenile arthritis, she said, I'm not sure, but I think it is. Her left leg is a little bit longer than the other one. So there seems to have been an arthritis process happening in this knee. When we actually examined that patient and found, yes, well, actually this child does have juvenile arthritis, it was a delight almost on her face, of course not for the diagnosis, but that she'd been able to get there.
How did that make you feel? Sure. Like, where have these people been all my life? As parents, we'd rather hide the things that we don't understand about our kids. But when they find a platform where somebody says, bring that child, I can do something, I love it.
So that's the story of that. Now, part of this is when you start screening for things like this, you find kids who have other problems, things that you don't know what's going on. X-rays like this get referred all the time. And so we started another thing called the Clinicians Champions Alliance, which, and we've developed grand rounds for the Champions Alliance, which offers an opportunity for people to bring in a rare disease that they don't have a diagnosis for from anywhere in the world and get connected to a panel of experts from all over the world who can then think about the case and try and come up with a diagnosis. The last video, I promise, and this one's very short.
Over 200 people registered.
Are you able to tilt it just a little bit? 30 seconds for real.
We're off and running. Have a good show, everyone.
I'd be really curious to know if anybody else has seen this.
It looks the same, but when you turn on your ultrasound machine and take the probe and look at it, it really leads you in a very different direction.
We have never seen such big masses in an infant before.
Very interesting that you say you can make the diagnosis as possible almost without an X-ray.
5OI is not supposed to do this type of crossing of joints.
Comorbid diabetes. So in our second patient with type 1 diabetes, this poses an additional risk for abscess formation.
They're the only ones I know of, and to hear about a third made me curious.
Some people thought they were FOP, and they were not FOP.
The devil's in the detail.
In South Africa, if you live in rural, to get these things, you'll need to sell a kidney.
I wanted to make a pitch for ultrasonography in rheumatology practice because it is really helpful in understanding the specific findings underlying clinical presentations that may initially seem very common.
That's very powerful.
So we'll be doing several of these, and I hope to encourage you to enroll patients if you haven't got them, or at least to join the panel discussion. You can also go to the website and look at the cases that still don't have a diagnosis and see if you can find a diagnosis for them.
Mostly
it's all musculoskeletal. Yeah, it's also spans all ages, but there are some really weird things in there that we still haven't got answers for. But they're there and they can be reviewed at any time, and anyone can put a suggestion in the chat box. So here's that law. Translated, the one that I spoke about at the beginning. In Brazil, they've made it a legal requirement for every pediatrician to look at the toes of every newborn child so that they can diagnose FOP. It's that simple. So how did this happen? Well, because of the movie, that's Odette Schregler, the movie maker on the far side, and that's Bolsonaro, the Brazilian president at the time, and in the middle is Patricia Delay, who is the pediatric rheumatologist that I worked with to take our patient to Brazil, where the whole movie started. So Bolsonaro saw the movie, and his wife was very moved, and they started to antagonize for this law to be put into Brazilian law, which actually happened, and it was enacted this year. So it's a very I mean, imagine that, such a rare condition, but a law in the Brazilian.
Are the pediatricians doing jail time currently?
I think it's less punitive. We're hoping not to jail all of Brazil's pediatricians. So, but this was us at a recent Champions Alliance meeting. The man sitting on the floor is Fred Kaplan, who's really been for the last 30 years, 40 years, the doyen of FOP. Almost everything has happened because of this man. But yeah, that quote that means it actually does matter. And I'm taking you back to Canada now because this is from the recent FOP, Canada FOP Network newsletter that came out. I'll read it. Pete and I started our family in 2002 with the birth of our son, Owen. 3 years later, along came our daughter, Miranda. When Miranda was born, our midwife pointed to her unusual big toes and referred us to a pediatrician for assessment, but nothing came of that. Miranda developed mostly typically until the age of 2, when lumps on her scalp suddenly started appearing. Thus began a medical odyssey of several months, culminating in Miranda being diagnosed with FOP in 2007 at 2 years and 3 months. Now, the next story is a little worse. When I was born, my parents first noticed that my big toes looked different, but the doctors dismissed their concerns as I was healthy. It was not until my 6-month immunizations, when I had trouble straightening my left leg, that things started. I was sent to an orthopedic surgeon who diagnosed me with myositis ossificans, and as there was extra bone in my left leg, the doctor decided to remove the bone and lengthen the tendon on the backside of my leg. The bone grew back after a while, and the doctors were stumped as to what I had. It took some research and a letter to Dr. Kaplan to get a correct diagnosis. I was eventually diagnosed at the age of 4 years old with FOP. So this is a map of where all the Canadian known FOP patients are. So I should mention Leanne Ward is here, and she looks after people with FOP, obviously a brilliant clinician and researcher. Angela Chung is in Toronto, also looking after people with FOP. And then there's one other center, and you can see the distribution of patients. But there's a lot of the country that doesn't show patients, and most of the patients in Canada that are known about are actually adults. Very few are children. In South Africa, almost everyone we knew about were children, but we didn't know about the adults. But it shows you a little bit about about who's looking out for the patients. And so we don't know where the other people are. They might be living in villages such as this. This is my son. That's him in 2010, and this is him last year in 2024, trying to do his best Bob Dylan impersonation. But this is just a reminder to me, is like how short time is and how urgent it is actually to find children in that childhood time, where you can actually prolong that 2010 moment just a little bit longer. It's actually quite urgent. You can't wait for these things to happen. So I invite you to email me if you, or reach out to us if you see anyone like this. I'd like to thank the following people: Adette Schwegler, Amanda Kelly, who's the philanthropist who sponsors all of this work, actually. Wahibas Lamang, who trained with me in Cape Town, is now leading the Tin Soldiers Project, the FOP, ICC, the Global Task Force, the film crew from Blink Pictures, and the patients who've shared their stories. And this, I'm a virtually completely crazy birder, as my team will tell you. And this story is something that if I have a minute, I'll tell you about. I was birding in South Africa, and I was looking for all the rare and wonderful birds, and this swallow kept flying in and virtually sitting on my camera. And I thought, I'm like Cinderella in that movie. This swallow just loves me. Like, he just wants to come and sit here and be with me. It's so wonderful. And I'm still filming, and the swallow just kept pestering me. And I'm like, what is going on? Eventually, I turned around and looked up in the roof, and I was sitting under the nest of the swallow, and the babies were sitting behind me quietly, too scared to cry out. But the mother was desperately trying to come and feed them. And here's this big oaf with his cameras sitting in the middle of them and misinterpreting this. So now when I sit in a bird hide, I check every corner of that place to see if there's a bird's nest before I go and sit down and take pictures. But it just shows you only see what you look for. I wasn't aware that there could be something like that in the bird hide. So it just teaches you that you can only see the things that your brain is looking for. It's on the slide. You can check them yourself. All right, but that's all. Thanks very much. I'll be happy to take some questions.
Thanks, Christian. And when we take questions, if you could just repeat any from the audience for the people online. That was an awesome talk, very inspiring. I took a list of questions, so I'll take the opportunity to ask the first one and then we'll open it up. Okay, I'll start with this one. That's an immense amount of advocacy work that you've done, and very specific to a rare disease. And when we talk about rare disease, we often talk about generalizability and what do we learn from that that can be applied to other contexts, other. Can you talk a bit about that? What have you learned about advocacy? What worked, what didn't work, what's generalizable?
That's a great question. The question is, what has been generalized? Well, you've asked the question in there, so I'm not going to repeat that. Yeah. So, that's quite. There's one strong learning point for me through this has been the power of storytelling. So, getting the film crew involved. Like a psychologist. I read something that a psychologist said at some point that humans have a capacity to care about other humans, but in a small village kind of setup. So people find it very hard to care about 10,000 patients in some other place. You can't care about 10,000 people. Your brain just doesn't have the capacity. So if you tell people there are 8,000 people in the world, probably with FOP, they can't care about all those people. It's impossible for them. But if you tell them the story of one person who might be living next door to them, that actually wakes up the whole thing. And so it's the storytelling is the key thing. And we as clinicians and researchers are so scared of using emotive language when we talk about these things. So we're taught to keep it cool, keep it, just give the facts, don't get emotional, all of that stuff. But that actually works against us because we all have this passion and this emotion for the things that we look after. But we struggle to get it translated because we're not telling the story in a way that is emotional because we're taught to be scientific and cold-minded about the whole thing. So it's this kind of storytelling, I think, that unlock is for me the key thing. And the film media is a beautiful way of doing that.
Yeah, thanks, Christian. That actually reminds me, we were in the Max Keeping wing, and when I first joined here, I joined the telethon once, and Max Keeping was sitting there telling me, okay. He was going to do the interview. He said, this has to be all about storytelling because we have to reach our audience. And anyways, just reminding me of that. Emma.
Thank you so much. That was awesome. I love coming to Grand Mountain for the reason that you said at the beginning, that you learned something new with everything. I'm excited about genomic newborn screening because hopefully we can diagnose this really early in a child's life. But I'm wondering if there's any injury that happens during delivery that if we can detect it prenatally, we can do like a C-section instead of vaginal birth, or that would be helpful for the patient.
No, so there's no evidence that it's that birth itself actually can be traumatic enough to cause permanent harm. Usually, those lumps, those early neonatal lumps, actually disappear very quickly. But it is possible to diagnose people in utero by doing ultrasound and looking at the big toes, and there are cases of that having been done. But the best is just at birth to screen the toes and have a look. I'm sorry, I should have repeated the question.
Yeah.
The question was, if you can make an antenatal diagnosis, should you be advocating for a different form of delivery, such as a cesarean section?
So the way Pranesh has done with the in utero delivery, but it seems there's a honeymoon period whereby in the first 2 years it doesn't show up, and then it's only in third and fourth and fifth years that you see the bumps, or is that?
It's a little bit. There's a little bit of variation, but in general, there's this honeymoon period where there's, for instance, one of the girls that was shown on screen came to me at 16 the first time. Right. She had at birth been diagnosed with abnormal toes. She'd gone for surgery to have those corrected. It's not an uncommon story. And even with that surgery, nothing sort of ossified, and no harm was done. And she came with perfectly straight toes with 2 little scars, but they were still short. But then she only presented at the age of 16. She was a cricket player and she was bowling a lot, and she was really bothered by the fact that her neck and her arm wouldn't move. And then from 16 to 17, she ossified virtually completely in a year. So something there are other inflammatory and environmental triggers that can speed things up. And there's one case of a man who's 21, now 24, who's got a different mutation in MMP9. He's got ACVR1 mutation and a mutation in MMP9, and he has gone his whole life without developing any FOP, but he's got just the toes. But they've shown that it's the MMP9 that acts as one of the cofactors in the and so there's a clinical trial. One of the drugs I showed there is a antibody against MMP9.
Not percent of cases are caused by a arginine switch-tail for histidine at 206.
Someone's done their homework. I'm saying someone's done their homework. Yeah.
Can do CRISPR genetic editing for these are largely de novo mutations not passed down from parents, but just happen de novo. If one can actually do a de novo CRISPR correction of that mutation, would that and you would be aiming for all sort of peripheral tissues to do that. That potentially would be a therapy. Well,
yeah. We've written that's certainly on the future.
If you just knocked out one gene, final question, Pranesh, I apologize. If you just knocked out that defective gene and you're haploinsufficient for that ACVR1, do you have a disease?
If you knock out the gene, you don't survive.
You just knock out one. You have one.
Yeah, you need. As far as I know, you need 2 copies of the gene just to
survive.
To survive, yeah.
This is large databases for the presence of the mutation. They've got tens of hundreds of thousands of DNAs just looking for the 206 to see if it's there.
So the question is, if people have screened big databases, have they found the 206 mutation in people? No, I don't think any work like that's been done. Yeah. Yeah. There's a question in the chat, and Leanne's got a question.
So Leanne, why don't you go ahead, and then we'll open up the chat here.
It's so nice to hear your life's work and very emotional. Very emotional. See the importance of the emotional side in the work that we do and getting messages out. My question to you is about these undiagnosed patients in Canada. Do you think we should be engaging more with orthopedic surgeons? It seems to me that they're probably going to be a portal of entry for patients in the system. Would you agree with that? And do you think we should be trying to work with them a little bit more?
I think so. I think pediatricians, orthopedic surgeons, and pediatric rheumatologists. So,
repeat the question.
Oh, the question is, where are these about the diagnosis of these patients in Canada? Should we be engaging more with the orthopedic surgeons to diagnose people with? And I think the answer is yes. And that's one of the projects that we kind of have. I've been to London to give a talk, and I've been to the name escapes me, Manitoulin Island, or I've done a virtual talk in Manitoulin, and I've tried to set up a talk in Vancouver, and I've trying to make the connections to try and give talk to general pediatric departments to give this kind of talk, but there's a lot of work still to be done to actually reach out to people, and if we should really reach out to the orthopedic surgeons and the pediatricians. It's really such a glaring difference. As you know, there are only 2 or maybe 3 children in Canada that are diagnosed, and 50 million people, so 42 million people. This is a mismatch. That's right, yeah.
By the time they come to, when people think of the pediatric osteologist like yourself, they're thinking medical management, right?
Yeah.
So there's a whole abyss there as they traverse through orthopedics and so on. And so I think that probably is important.
I'm saying there's a whole abyss of diagnostic pathways before they get to an osteologist like herself, and that's correct. And the word abyss is the right word. And the diagnostic journey, we've actually got a separate little video on the diagnostic journey where we describe a patient in South Africa who's come to the age of 30 without knowing that he's got FOP. We eventually went to his house, diagnosed him, and then realized he has a girlfriend and had a child, and the child was 2, and it's autosomal dominant, so the child had abnormal toes, and we could diagnose the child just on that visit. But if you don't get that diagnosis, then you work a whole gambit of things, including what these other patients in Canada have described, a really difficult journey to getting a diagnosis, which is actually so straightforward.
First, I have to go to the chat, and then we'll go back to the room. Yeah.
There's a question by Eman, do they all present in the same way in terms of severity, or is it a spectrum from mild to severe? So there appears to be some sort of spectrum, but on the whole, the graph is fairly linear. If you aggregate everybody, the graph just goes from starts off okay and ends up terrible, and the straight line in between. So there's some variation in that curve. Some people, because of trauma or infections or other things, might develop more quickly in the early part of their lives, and others. But sometimes you look after a patient, like the first one, patient I diagnosed at the age of 6. She was absolutely fine until the age of 16, and then everything suddenly ossified, and she went into a wheelchair. So it can be variable, but we measure something called a CAGES, a cumulative analog joint involvement score, and that follows a linear thing across ages. There are other mutations, variants, and they present sometimes with no fingers, no toes. They have a more severe phenotype usually rather than a more mild phenotype.
The bones was lower if you fix it.
No. Do the bones resorb if you fix it? So even with the medication we've got no evidence that you can reverse ossification. The hope is that we'll be able to get to a point where you can at least remove bone and prevent it from coming back. And so that'll be the next big set of clinical trials, is trying to break open jaws and prevent ossification from happening again, and then trying to loosen an arm, because it's these little movements. If you can just do this, that's a big difference to this. Or if you can wipe a tear away or scratch your nose, these are big differences to patients. And one of the reasons people are reluctant to enroll in trials is they say, I don't want to lose anything. I can't afford to lose anything. So I don't want to go into a clinical trial just because that's an additional thing. They might put an IV in my arm. That might hit the muscle. That might ossify. And then I lose this 5 centimeters. That's a critical 5 centimeters for that. So it's unbelievable how these small movements can impact quality of life. Leanne.
On the Pediatric trial, they looked at the new ossification volume, right? Whole body CT, how much new heterotopic ossification is there, without any attention to the impact of the ossification at the jaw or this future clinical trials doing a better job of looking at the significance of ossification by CLS.
Absolutely. So Leanne's mentioning that in the trial for which palovarotene was approved, they measured whole body heterotopic ossification by CT in a volumetric way. So you could measure, so many cc's of bone, and now they've got so many cc's of bone. But there was no functional impact. And that was one of the reasons why palovarotene was very difficult to approve as a drug, because we couldn't say that people had any better function afterwards. We could just say they had less bone. But if you've got a 0.5 kilogram of bone holding your hips together, or you've got 1 kilogram of bone holding your hips together, makes no difference. Your hips don't move. And so the hope is for total abrogation of ossification. So palovarotene kind of reduced things by about 60% on average, but we're not sure that it really limited, stopped people from losing function. So that's a critical thing. And I think the new trials will be, as far as I can tell so far, I mean, the amazing thing is in mice, there's an FOP mouse where you can, various models, but in mice, these drugs can completely and absolutely stop heterotopic ossification. Even palovarotene did a great job in mice.
You need to find a wealthy mouse.
Exactly. But the human thing is different.
Yeah. Any other questions? If not, I have one super quick one, I think. Is this limited to skeletal muscle, or is there any cardiac muscle or smooth muscle involvement?
That's a great question. So the only muscles that are spared are the tongue, the ocular muscles, the heart, the diaphragm, and all the muscles in the intestines and the genitourinary tract. So it's skeletal muscle, but muscles that a smooth muscle doesn't seem to be affected, and muscles that move all the time, even skeletal muscles that move all the time, like the eye muscles, don't seem to become involved. It's quite strange.
Okay.
The first thing I would do would be X-ray.
our radiologists be able to tell me if this was FOP or not? Because then my next step would be like, oh, there's bone here for orthopedics. But if there was a catch in between,
So the radiology is interesting. So if you ask the right question of the radiologist, you'll probably get the right answer. Otherwise, you'll get correlate with clinical picture. And but so if you take X-rays of the feet and ask, are the toes short and malformed, and is there a missing joint? That's probably almost the best thing. I get sent a lot of X-rays from all over the world. Sometimes it's calcinosis, which is very different in pattern, very easy to tell. Sometimes it's enchondromatosis, which has a very particular look about it, and it all originates from the bone and moves out. But the FOP ossification is kind of specific in that it looks like healthy bone. It's not the salt and pepper calcification. It looks like a solid piece of bone, sometimes attached to another piece of bone, but often just on its own. But there are many other radiological features. So if you just X-ray the tibias, for instance, you'll see these enchondromas in the tibias virtually in everybody. If you X-ray the thumbs, you might see shortened thumbs as well. So there, you might see ankylosis of the neck quite early on. That person that I spoke about, who was a cricket player, she was referred as ankylosing spondylitis because of ossifications in her neck, because of ankylosis of a cervical vertebra. And there's another thing I wanted to say. Oh, you might see some hip dysplasia on X-ray. So if you ask the right questions, the radiologists will look and then go and look at their atlases if they don't know. But I think a lot of radiologists are attuned to this because it must be something that pops up quite regularly in their exams or whatever. But if you ask the right question, you get the right answer. But often I get the radiologist says this is FOP, and you take one look and it's like, no, but that just isn't. And then you just have to look at what we always ask. The next question is, can you take an X-ray of the toes? Because that's really the answer.
Okay. Well, thank you, Christiaan, again, and thanks for all the discussion. Even Alex,
I'm usually so quiet.
I think we have to get a microphone for Alex. Everyone on the virtual can hear his questions as well. It was really good, actually. I'm only half joking because we have to be able to hear the conversation, I think, online as well. Yeah. Okay, but thanks again. It's very inspiring. Thank you. Thanks everyone online.